시청자 여러분 안녕하세요.
Ladies and gentlemen, greetings. This is Prosthodontics on Friday Live, which addresses different steps in implant treatment as well as its side effects. Prosthodontics on Friday has returned with the start of July. Today we have with us Dr. Sang-ho, a guru of screw-type zirconia implant prosthesis, to talk about screw-retained implant prosthodontic treatment. Greetings. I'm sure you're very busy providing treatment. Thank you for coming to Prosthodontics on Friday. Dr. Sang-ho, you're a guru. You're really renowned for your knowledge in screw-type zirconia prosthesis. I'm honored to have you. Can you briefly explain your lecture? Thank you for inviting me to this prestigious program. Today, I'm going to talk about what kind of prosthesis is most advantageous in digital era after looking at how implant and implant prosthesis have developed. Listening to you speak, I feel even more intrigued by today's lecture. I look forward to thank you. To viewers watching the program, you can participate in the program via the chat screen, leave your questions, and get your answers. Through a lucky draw, you'll get Starbucks coffee coupons. Best question will be chosen, and the person who raised the best question will receive 3 coffee coupons. Study your implant prosthodontics and get your iced coffee coupons. Please note that you need to agree to marketing on dental site to be able to receive coffee coupons. I look forward to your interest and participation. Let us begin Dr. Sang-ho's lecture. Greetings. I'll now begin my lecture. Era of digital dentistry, now is the time to do screw-type implant prosthesis. This is the title of my presentation. The contents of the day: developments in implant body design, developments in implant prosthodontics, latest implant prosthodontic systems, ZSRP concept and traits, and HERI system cases. First, let's look at developments in implant design. The design in 1965, it was like this. External connection type was used. In 1974, tissue-level implant was introduced, and in 1985, Astra-type implant was introduced. Implant designs have emerged every 10 years. You can see the changes. External type changed to internal, and bone level implant changes to tissue level, and then it changes back to bone level implant. Currently, these are the main designs that we have witnessed over the past decades. Let's look at how implant prosthesis have developed. How has it developed? At the time of the implant innovation, it was used primarily for dentures rather than for implant patients. It was used to support other prostheses like bar overdenture. Abutment for single tooth, conical abutment was introduced. Standard abutment and conical abutment. There's abutment screw that tightens implant, and the crown is tightened by 16 newtons on the abutment. 2 screw is used. In other words, it has a 3-story structure. when you look at the patients, if they have these prostheses, there's many to check. On the other hand, UCLA, it is tightened with one screw, so at periodic checkup, you just need to check this one screw. As shown in the UCLA case, if the design of prosthesis becomes more simple, it has more favorable long-term prognosis. This is a cement type that was introduced by Straumann, and CAD/CAM was introduced in dentistry. Custom abutment was introduced since. Zirconia became more common in dentistry, and people came to think that everything may be possible with the use of zirconia, and zirconia abutment was introduced. If you look at recent study, when you use zirconia abutment, zirconia can cause wear on internal surface of implant body and can damage the implant. The result of this study was that it is not ideal for zirconia to be in direct contact with implant, and it is suggested to change this part with titanium. This is the link design. In upper anterior, cement abutment. Within it, there is this component that prevents direct contact between implant and zirconia. For posterior area, these are the links for zirconia screw-retained prosthesis. If you use these short links with bevel in the posterior area with the crown, this may fracture. Therefore, hairy abutment or hybrid abutment or tie-base abutment. Different types of screw-retained prosthesis were introduced. There are cementless systems among screw-retained systems. DHL system. This was introduced a couple of years ago, but it does not have a lot of clinical background. If such crown design goes in the posterior area, considering how tough the food people consume in Korea, I believe it will fracture. With the elasticity of the slit, this design does not use cement, but there are risks associated with fracture. Therefore, not a lot of people use it recently. Highness system is also a cementless system. It's a solid type. The screw is fixated, and on top of it, another screw is fixed. This is a 3-story structure. Therefore, there are 2 components. It may be quite expensive in terms of cost. These are cementless types. As a prosthodontist, I don't believe cement itself is bad. Excess cement that remains in the gingiva, that's problematic. Cement within a gold crown with good fit, even if 10 years or 20 years pass, it's not going to be a problem. The problem is excess cement. The cementless system opts out cement, and in the dead space, there can be potential of anaerobic bacterial growth. Easy crown also has 3-story structure. Abutment is tightened and crown goes up on that. It has a complicated structure. The crown is retained using the elasticity of a ball, but this structure is unfavorable long-term, in my opinion. This is a new system. With friction, the crown is retained. This is also a 3-story structure, Django abutment. There's no clinical experience using this abutment. This system is cementless. I believe there may be potential issues with micro gap. Uncontrolled cement is bad cement. In the case of Harry's system, it is a ZSRP, zirconia screw retained type. Abutment and crown is bonded. It's a type of gold UCLA. The white gold is changed to titanium and the gold is changed to zirconia. It is a modern type of UCLA. Let's look at implant prosthesis briefly. The most notable screw type is gold UCLA, and there is cement PFM. SCRP and most recently introduced ZSRP, which is a zirconia screw retained prosthesis. A lot of people use cement retained implant prosthesis. What are the advantages? First, you don't need to use gold. So it's good in terms of cost, and even if implant is not placed accurately, you can compensate for that using crown, and lab process is simple. When a solid abutment was first introduced by Straumann, it was very intuitive. You place implant in gingival level and you tighten solid abutment and you would put in cord and take impression like natural tooth. Using cement is easy, but there are disadvantages as well. The benefit or advantage of cement type is it's easy and cheap, but when problems rise, it is impossible to remove it, or it could fall off even in cases where it shouldn't. There could also be issues related to excess cement and also peri-implantitis. In treating implantitis, if you can remove the crown, treatments can be made more easily. But in the case of cement type, it's difficult to separate crown. The opposite type of cement type is gold UCLA. It is expensive, accurate surgery is necessary, and you need to pay a lot of attention in taking impression. But once it's completed, unlike cement type, you can untighten it and remove it. You can also respond to contact loosening. In treating implantitis, you can separate it and make necessary treatment. Cement type is good for the surgeon in many ways, whereas gold UCLA is beneficial for the patient in many ways. SCRP was introduced to remove excess cement problem with cement type. You use the same abutment as cement type. This removes excess cement, but you need to do more work because you need to do cement type related effort, and then you need to untighten it, polish it, and do the process related to screw type. Also, if the VD is narrow, the SCRP can also fail, same as the cement type. Both types have the same problem. The advantage of ZSRP is utilizing digital dentistry. It has the benefit of zirconia added to the screw type. Zirconia, gold, lithium disilicate can be used, but zirconia has many advantages. Therefore, a lot of cases, zirconia is used for crown. Can I ask you a question? I believe ZSRP, zirconia screw retained prosthesis, has many advantages. It seems like a good system. One concern is compared with existing systems, will it be more costly? Next, I'm sure you have a lot of experience with it. After you tighten the screw, will there be issues related to screw loosening? Screw loosening can be a big problem. I'm concerned about that. Thank you for your question. Regarding screw loosening, I believe accurate prosthodontic planning is very important. For example, the conical abutment in the Ronemark implant system was tightened to 25 Newton. The gold crown was tightened with 16 newtons of torque. By 16 newtons, it's about the amount of force that is applied when you use your fingers. I've seen many cases where with even that, if the implant has been placed in the right direction and has the right contact and occlusion, the implant didn't loosen. It's not a matter of torque, but about the correct treatment plan. Through loosening an internal type, rather than a problem with prosthesis, I think it has more to do with occlusal force. Even if you tighten by 35 Newton centimeter due to sinking, caused by chewing on tougher food, this can cause problems to the implant and it feels as if screw is loosened even though it isn't. I've talked about 3 different implanted types. I think that is disadvantage of internal connection. You need to understand the pros and cons of different systems and do periodic checkup to address them early on. Thank you for your answer. There are many comments on the chat screen. Let's take a look. Godzilla, I've come to see the live program. Thank you. Good doctor, Professor Joino, Dr. Omsang-ho, greetings. ID Dororo, Prosthodontics on Friday, good luck. Many people have left comments of support. CMIM6, implant longevity, it's rather short. Is there a good product? I think OSSTEM is #1 implant company. Thank you. Thank you for the wonderful answer. I use OSSTEM a lot. ID, I love you. There's a question. I've heard a lot about Harry system, and I've looked at a lot of images, but I have no experience. I don't know how it is set actually. It's still unclear. Is there a micro leakage in space without cement? I believe this will be addressed by the doctor as he talks about the system and shares his clinical cases. How to set the prosthesis and the fact that it's cementless, it's going to be discussed. I look forward to Harry's system. TS raised this comment. If a patient who has received implant treatment, if the patient complains of inflammation or pain, what do you do? CMIM6. I believe this is due to multiple causes. Today, the topic is about using system without using cement. I believe using that could be a solution. Regarding your question, sometimes there are vague situations. If there's inflammation and the patient is complaining pain, you know what is causing it. The approach is clear. You can remove inflammation. In my case, I use a screw type. I detach the crown and use diamond burr to do polishing, or I extract it and place it again. If the surgery has been done nicely and ISQ value is good, and if occlusion is good, yet sometimes the patient says he or she feels weird. In cement type, this is not possible, but screw type, you can disintegrate it. I've measured the ISQ value once again. At times, patient is right. Originally, it may have been 80, but within 1 or 2 weeks, the numbers may drop. In that case, due to unknown causes or biological reason, problem has occurred with the implant and the patient noticed it first. In this case, I have the patient wear the healing abutment for about a month, and after that, I check the numbers once again and respond to it. In other cases, if I measure ISQ, the value is even better. It means it's very good. If the patient is complaining of pain, you can explain that ISQ value has improved and that implant treatment has been done successfully. You can say with conviction that the implant is without problem. And this is possible with screw type. Hot summer. I think there are similar systems. What is the advantage of hairy system compared with other system? I believe this will be addressed during your lecture. Then we'll stop here and resume with your lecture. Please carry on with your lecture. ZSRP, which is a type of cementless prosthesis, it's actually not without cement, but it does not have excess cement. I'm sure you're all aware of SCRP. You do cementation on the abutment, and after that, polishing is done after it is disconnected. The SCRP process ends in the lab. The advantages it has: it reduces the dentist's chair time. Let's look at the principles and characteristics of zirconia screw-retained prosthesis. In looking at review, I wanted to see if there was something that made the screw-type prosthesis using cement. In 2006, this was reported. On stuck abutment, tested prosthesis was cemented. On the model, screw-type was formed. In ZSRP, as mentioned before, screw type has many clinical advantages, and zirconia has also many benefits as well. Zirconia screw-retained prosthesis is a combination of zirconia and screw type, and hairy system is one of ZSRP. As mentioned, SCRP, the abutment comes from cemented type. Therefore, it also shares disadvantages. Because the superstructure is tapered, if the VD is low, it can be dislodged. This problem is seen for SCRP and cemented type. In the case of a hairy system, it has vertical prosthesis design, so it has very great retention. Like a gold crown, retention has been maximized. In order to maximize it, hole has been formed. If a hole is formed on the abutment or crown, resin ball is formed. In order to detach the crown, fracture of resin ball will be required. By using this principle, retention was maximized. Another characteristic is its height. Zirconia screw type uses minimum color. It maximizes subgingival zirconia portion. On the other hand, SCRP or cement type, there's much more metal portion on the subgingival level. In other words, if there's more ceramic portion, it's more aesthetic and healthy. If you look at review in 2015 IJP, this was reported on X-ray. You cannot see cement, but if you open flap, you see excess cement. And because of that, a lot of inflammation can occur. The dilemma of cemented type is about how to prevent excessive cement. In order to rectify this problem, cementless options are available, but first, let me raise a question. If a gold crown is made perfectly, what is the problem with the cement inside? The problem is with uncontrolled cement. If you remove cement entirely just because of uncontrolled cement, then anaerobic bacteria can be formed in such dead space. There can be various problems due to such gap. If the dentist used screw type, there would have been no excess cement. This is not a case done by eye clinic. I'm sure this person did not want prosthesis to come out like this. If it has been placed deeply in number 7 in the upper, even if you use long stock abutment, pocket depth is too deep, so it's very difficult to remove cement thoroughly. This is Harry system and gold UCLA system used in the past. The basic principles are the same. The gold has changed to zirconia and white gold below has changed to titanium. After 2 years, there's a lot of plaque accumulated on gold, but there's no plaque on ceramic. In other words, it's healthy. These days, it's tough for dental clinics. Changing prosthesis can be another source of income. When patient comes by, the first thing I do is to put floss on the mesial side of the implant done by another dentist and ask whether there's a lot of food impaction or not. In most cases, there's a lot of food impaction. Cement type, it's difficult to respond to this, but you can say, if you use zirconia screw type, you can prevent the food impaction. In cement type, when placed deep, emergence profile and margin gap may look very unfavorable. However, if you change it and form resin box in contact area, you can easily unscrew it and adjust the contact. Let's take a look at a case. The patient was using cement type for long term. The patient also received the surgery for implantitis, but the problem did not resolve. Due to inflammation, the patient came to my dental clinic. When you look at X-ray, as mentioned, if you use tissue-level implant in anterior aesthetic zone, you need to place it deep. It's a disadvantage. If you look at CT, it was inclined excessively, therefore implant had to be removed. You can see excessive cement here. Implant has been placed. Again, I used the Harry system. The patient has been using it for 10 years. Compared with the prosthesis on the left, it looks much more aesthetic. The reason is because I did a partial laminate fabrication here, adjusted the size, and I've achieved a much more aesthetic and healthy result. I have 10 years of clinical experience with this. 10 years ago, I used Emax and now I use zirconia. This is a case of abutment exposure. This was done by a different dentist. The surgery was done nicely. Sinus graft was done nicely. The implant has been placed correctly. Problem is, the dentist used cement type. At the time, there may have been no issues, but due to natural resorption of gingiva, abutment was exposed to oral cavity. I recommended doing prosthesis again because it was unaesthetic and new implant and prosthesis was provided. If you look at this prosthesis, the advantages it has, I changed the prosthesis, the gingival height. If it is here, it's the same. It's pretty, but with gingival resorption in subgingival area, if it is made of zirconia, it's aesthetically more favorable and it's more healthy. Because this is more healthy, it's still okay if you use implant more deeply. In the past, I used to place implant with 3 mm of gingival depths. As of late, I place it with 4 mm depths. Emergence profile is much more beautiful even though it's just 1 mm difference. You can get an appropriate emergence profile in the molar area. If you look over here, SCRP uses the cement type abutment. Therefore, hex type abutment is used for multi or single cases. In multi-case, if the path is slightly unfavorable in number 6 and 7, it can get stuck and you'd not be able to remove it. When you place implants in number 6 and 7, it may be difficult to remove cement. You need to detach it and polish it and then connect it once again. If you set sufficiently, because of the hex, you may not be able to detach it. You may have negative memories regarding this. This is because you've used a hex in multi cases. ZSRP, which has evolved from traditional UCLA method, it uses non-hex type. Even if two implants are deviated by 22 degrees, you can attach and detach easily. In single, you use hex type, and for multi cases, you use non-hex. It has such advantage. In multi-case, the crown is cemented separately and the prosthesis is fixated. Therefore, because of this angle, even without the cement, unless you unscrew it, it does not fall out. This is a major advantage. There are such advantages due to the design of the abutment. In using screw type, when placing implants in number 5, 6, and 7, rather than connecting all 3, I suggest connecting just up to 2. Accuracy of the fit is essential mechanically, and therefore, if you connect at 3 or 4, there are higher risk of misfit. Therefore, you can connect up to 2. In the case of placing implant in number 5, 6, and 7, you need to make number 5 single because it is a subgingival ceramic. In most cases, there's no problem, but if you connect the implants, you need to unscrew because of contact loosening. If all 3 are tied together, you need to unscrew all 3. But as for number 5, if it is made in single abutment, you can just unscrew number 5 and adjust the contact. In the design, there's the resin box in the contact area. It's like an undercut or amalgam box, so it is filled with resin and you can add more resin if needed. ZSRP is optimized for digital workflow. Scan body is a digital impression coping. If you scan body, you can get prosthesis. When you use screw type, complete the prosthesis results. So you just need to connect it in oral cavity. The abutment and crown are separate with the traditional method. Therefore, the dentist has more work. If you use digital workflow and use a screw type, you can just connect it. I've mentioned about retention and aesthetics as well as gingival health. Contact loosening can be fixed using the resin box. You can, in the end, reduce chair time. When you scan using intraoral scanner, the impression-taking method is the same for cement and screw type. You don't use gold type, so the material cost is the same. In doing guide surgery, you can place the implant ideally using the top-down method. If you use a cement type, you get cement type prosthesis, and if you use screw type, you get screw type prosthesis. Rather than doing cement type with barely any clinical advantage, why not try screw type? When the VD is narrow, because it is right angle, you can use it in these cases. When I first adopted digital dentistry, I was unsure whether scanning was accurate. After scanning, I did not remove it. The scan body, as if connecting impression coping, I connected to light curing Duralay and made dye to see if the scan was accurate. What is important is not whether it's 100% digital or not. You need to provide most accurate prosthesis using the available technology. If you use this kind of tip, you can make a CRP on this die. This is analog process. Setting zirconia crown and titanium abutment is done with your hands. This is analog process. If you have a guide for that, it will be more favorable. X-ray is also important. Scan body needs to go properly. It's very difficult to check internally. There's a slit. The slit should be invisible. In this way, you can know that it has been connected properly. If you connect the resin here, if the prosthesis does not fit, if you connect it to the model, you can see that it does not go in. You can see that you have taken impression wrong and that prosthesis does not go in. As for verification, unlike the past, if you use light curing Duralay resin, you can make extremely precise model using this. Let's look at a case. This is a 63-year-old female patient. The patient has been using denture for over 10 years and there was a lot of bone resorption in the lower posterior area. 5 implants were placed in the mental foramen area. This was mother of my peer. Prosthesis was provided like this. If I had not used digital dentistry, the prosthodontic phase would have been very difficult, but using the digital dentistry, I was able to swiftly and accurately provide a fixed hybrid bridge. I like to do surgery using tissue punch. If there is sufficient attached gingiva, I use tissue punch and place the implant. This is provisional. This is final prosthesis. Before connecting an abutment, this process is analog. In order to do analog process, you need stone die. You don't need to remove stone die just because you want to do 100% digital dentistry. This is impossible with current technology. It's not important whether you perform digital dentistry or not. What is important is how we utilize the available technology to provide swift and accurate prosthesis. I wanted to show you this video. This is screw type, but without any anesthesia. You can just apply 10% lidocaine in the hole and then you can set it. Final prosthesis can be completed by just connecting the delivered prosthesis. If this was a cemented type, you need to position the abutment which is connected to jig and you need to check the crown, do occlusal adjustment and then do cementation. It would have taken a long time. I completed setting within 10 minutes for full upper restoration. As you can see, I'm tightening it, position, and then tightening again. I'm using 10% lidocaine topical agent appropriately so there's no anesthesia needed. Setting is done very swiftly. This is tightened by 10 Newton. I'm checking the contact and occlusal adjustment is done. As for screw type, while using irrigation using diamond burr, you can adjust zirconia quickly. Proxa brush needs to go in for good maintenance. I don't use GP cone, but I used Teflon tape and am finishing up the resin hole. Resin is filled, prosthesis is complete. Setting is very quick. This is a major advantage. If I were to do this using the old days method, it would have been very difficult, but using digital dentistry, I was able to do it very quickly and easily. This was a more detailed explanation. Implant was placed. In placing implant, I placed implants in the front and middle of mental foramen. Tissue punch was used for second surgery. This is important as well. Resin bite is done. If you use resin bite, you can get very accurate bite scan. As mentioned, the number of implant bodies tied together should be 2 at most. In the case of lower, when extension is imperative, you can tie it like this, but still you can see that using digital dentistry, this has been made very accurately. Thank you for listening. Oh, you've paid a lot of attention to it. I can see that you've shown us a video and you're right on time. I really appreciate that as well. There were so many questions. Now that your lecture is over, we will revisit the questions received. 18608, cement free. It looks very nice. In doing trial setting, due to tight contact with adjacent teeth, if you do it with the abutment, won't it be more difficult to do the try-in? So if you make it ahead and then do seating, will the contact be too tight and uncomfortable? Regarding contact, when you do scanning, I tell my patients that it's similar to trimming branches.
저희가 이제 자연치를 저는 이제 환자분들한테 그 뭐 가지치기 뭐 내지는 저기 뭐죠 전지한다는 말을 가끔 쓰거든요. 왜냐하면
Implant prosthesis is something that patients need to be able to use for long term, so polishing is needed a little bit on the antagonist and adjacent teeth. If contact is too tight, in that case, you probably try to conserve natural tooth too much. If you do appropriate polishing, I believe it will fit properly. Because the contact is made of resin, it can be adjusted easily. You need to make it ahead. You need to be careful so the contact is not too tight, but because it's resin, you can adjust it. If you adjust it too much and if it becomes loose, can you adjust that as well? Yes. What I want to say is digital scanner is very accurate. I only do screw type implant prosthesis. I've never been stressed because of contact. When I look at cases of other dental clinics, I've seen implants being placed too deep. At times, prosthesis does not go in not because of the tooth, but because it hits the bone. Because immediate implant placement is more widely done these days, because the economic condition is worsening, it's difficult for dentists to bring in patients frequently. Therefore, they just go ahead with surgery and place the implant deeply. Bone profiling may be needed in those cases, but because prosthodontically scanning is very accurate, therefore I've never experienced such difficulty. Because contact is made of resin, I believe adjustments can be done easily. I think this question is a little bit outside of the context because it's about hot food and tough food. CMIM 6. I'm curious about AS. Requested regarding AS is made only in regards with contact. When there's contact loosening, you need to add contact resin. In the case of prosthesis that is not insured, it's similar to car insurance. You need to tell the patient straightforward from the beginning that I'll be able to adjust it up to 3 times within 5 years, and after that, the patient will have to pay for additional cost. If you tell that to the patient ahead, the patient acceptance increases. You need to tell the patient that you're going to adjust and fix the problem up to 3 times. OMSLWY. I believe this person is an oral maxillosurgeon. When I connect the prosthesis without cement, I think we need to be prepared about screw loosening. Is there a know-how? Do you do retightening at periodic checkups? At periodic checkups, I don't do retightening. In a recent journal, it says you should tighten once and wait 10 minutes or 2 weeks and then do retightening. This leads to far less screw loosening. At the day of adaptation, you tighten, and I do retightening after a week with final torque. At periodic checkup, I don't do retightening. So you don't really concern yourself with screw loosening. I use external type mostly in my dental clinic. Actually, the downside of external type is screw loosening, but that has more to do with the gold that was used in the old days. When you use titanium, there's no casting process, so it's much better. TS. What do you think of CLF? I think I need to study on this topic. I'm not really sure of CLF. I think this is a crown system. CLF system. Dr. will provide an answer separately after researching into the matter. Lee 74NEN. Why is it the best digital scan type, although it is zirconia material? ZSRP. Why is it the best? Digital dentistry is difficult when you take impression of natural tooth. As for implant, it's a type of digital impression coping. Three-dimensional position is remembered. There's no margin concept. The margin comes from the library. What kind of hex? The three-dimensional position. These information needs to be taken note of. It's much more accurate than taking impression scan of a crown. The scanner scans antagonist very precisely as well. If you use alginate, the deformation can occur. Therefore, using scanner, you can get much more precise prosthesis. When you use digital scanner and make prosthesis, at times you don't need to do adjustment at all. That's quite amazing. ID Ryong. What kind of tools or equipments do I need to buy to use this system? Can I just use the screwdriver that I use? You don't need to buy anything else. If you have scanner, things will become much more quicker and easier. Or you can use pickup impression coping, like doing pickup impression. I believe Ryong has oral scanner. Then you just need scan body. According to statistics, 1/3 of Korea's dental clinics have oral scanners. OMSLWY. Multiple retightening can lead to fatigue, fracture, or dullness of existing screw. Do you replace it? How frequent do you replace the screw?
실제 이제 어떤 그런 무뎌지는 거를 이제 느꼈을 때 이제 장 이렇게 35뉴턴 토크 줄 때 이제 그런 흔들리는 느낌. When you give 35 Newton, if you feel it's rickety, I change it to a new one. I don't have a protocol as to how many times I retighten before switching it. The size and material differ when it comes to driver. When I use OSSTEM driver, I think damage to screw is minimum. Drivers from other companies, I get a lot of issues with screw. ID, I love you. After try-in, if I do setting in an ER type of way, you do setting without cement. Is there a difference with my way? 제 생각엔요.
In my opinion, implant prosthesis is a work of art.
작품이라고 저는 생각하거든요.
It's a work of art provided to a patient. In order to provide a good prosthesis, someone needs to put in absolute amount of time and effort to come up with that work of art.
그래서 그게 그 공을
The amount of work that is put in, you need to make a decision as to who's going to take up lion's share of the work, you or the lab. With screw type, you put in time and effort with scanning and taking impression and have the lab technician take up bulk of the work. With SCRP, impression is not emphasized because cement gap is utilized to enhance preciseness at chair side. The dentist needs to put in more work in this case. I'm not saying that this method is wrong,
많이 들여야 돼.
but it may be more uncomfortable. There's an easier way. Why do you spend your precious time in chair side? If it is precise and quick, that's good. For dentists, time is money. You can save time and the amount of effort that is required. Exactly.
그러니까 시간도 절약할 수 있고 노력도 절약할 수 있는 방법이
What is different compared with that of other companies?
타사 제품
I think you have already mentioned the advantages. We'll skip this question. KY Perio, compared with SCRP type,
SCRP 타입
do you use screw type more clinically?
사용하고 계신지 궁금하고요.
How often do you do follow-up to prevent screw loosening? By how many newtons do you do retightening?
몇 뉴턴 정도로 조이시는지
I use a screw type 100%.
아, 저는
I've tried SCRP in the past. SCRP itself is not bad, but you need to put more effort at chair side. Therefore, it can be quite
대해서 드려야 되기 때문에
quite
의사
tough for dentists. In screw type, when dentist pays more attention in impression taking stage, you can get much easier.
그 뒷단에서
예.
훨씬 편해질 수 있다라는 이제 말씀을 드리고 싶고요. 스크루 루즈닝
Screw loosening. I use a lot of external type.
스크루 루즈닝이
People say external type has a lot of screw loosening, but that's not really true. In order to prevent it, I do not do additional tightening. I apply 35 Newton centimeter at adaptation and once again at final setting. Thank you.
그래서 두 번을 조여주고 있습니다.
아, 예. 알겠습니다. 감사합니다.
Good day. It looks very similar to SCRP type crown. ZSRP. Is it different in terms of abutments, indentation, and mechanical retention of crown?
SCRP는 기본적으로 SCRP 타입용 그
SCRP does not have a dedicated abutment. Cement type abutment can all be SCRP abutment. Cement type abutment is basically for crown setting within oral cavity. Therefore, the superior portion needs to be tapered for easy seating of the crown.
GSRP는
In the case of ZSRP, it is set at the lab. It has a right angle, but it's done manually. What is most different is whether it has right angle or not,
그
and whether you can use non-hex in multi cases. Abutment indentation is just something additional. Is repair possible at dental clinic even if I don't have Harry's system? It may vary, but
치과에서
if you have done cement type zirconia crown, two-piece abutment,
크라운을 하셨다면 그 투피스
you need to make access hole on the crown, or if you already have that, you can remove it.
만들 때 그런 만들어 두셨다면 풀러서
예.
매지 아래 그 저기 매지 아래
On the mesial side,
그 홈을 파주실 수가 있어요.
you can make indentation there. You can put resin there. In contact area, amalgam box is formed on zirconia. You can fix contact loosening using this method.
예, 알겠습니다. 그리고
Lee 74NEN.
74
How much resistance does the resin ball have? I filed for a patent regarding resin ball.
그 아이디어를 내서 이제
As people use Harry system more, I think the university is going to research on that.
이제 대학에서 그거를 이제 연구해 보지 않을까 싶습니다. 저는 뭐 그냥
I just have
현상이 생기겠다.
an idea that it will get more retention, but there's no data. My question is, if you use resin ball,
사용하면 그러니까
it may vary depending on patient, but does it prevent contact loosening? Contact loosening is not because of prosthodontic issues. It's because of mesial shift of tooth. It's a physiologic phenomenon. All implants have this problem. We can fix it.
발생되지만 이제 저희는 고쳐줄 수 있고.
What's different is that we're able to fix it. Flossing is important. Even though it feels loose when the patient uses floss, if the patient says it's okay, then it's not a problem. Do you have any statistics? My mentor, Professor Dong's review says it occurs over 90% of the time and it occurs more frequently in the upper and mesial side. ID awesome. When there's a problem with the crown and if it needs to be removed from the implanted body because of cold welding abutment, it does not come off. What should I do? In those cases, you can use the back side of mirror.
미러 뒷면으로 그 사이드에서
Bang on it from the side.
그러면 이제 어느 순간 소리가
The noise it comes out will change at a certain moment and then it will be removed. Bang on it. Do you use ultrasonic scaler? I think everyone has their own way, and I just use the back side of mirror. Up until now, I have yet to experience a case where it didn't come off. 3992875. Excess cement seems to be a primary cause of implant inflammation and failure. Question on anesthesia. I think this is a little bit out of context. ID awesome. When you make a resin box on the adjacent surface, sometimes the resin falls off. What do you use to increase the bonding between zirconia and resin? Rather than chemical bonding of zirconia and resin, you need to adjust the box design to undercut. You need to form amalgam box.
그 디자인을 만들 때
The contact point is going to be slightly oval. In the case of posterior area, it's going to be flat ovoid form. If you make this design, the floss is going to get stuck there. You need to make it almost triangular like a guitar peak. You need to make resin hole like that to be able to add resin without issue. If you increase the amount of prep, you'll be able to prevent it falling off. Rather than circular shape, it should be more triangular. If the contact is like this, up to gingiva, you need to extend it slightly more. TS. When you do prosthesis, is there a necessity of using angle driver? I think it's a matter of direction. I get a lot of questions in the anterior region. When there's a will, there's a way. If you are committed to using screw type, there are ways. I found ways. TS. Does sinking occur in Harry's system? In the first slide, I've talked about different implanted types. I believe it's a primary problem with the implanted body. For example, regardless of external or internal type, implant has a little bit of sinking, especially in Astra type. That's the structural disadvantage of Astra type. If you don't like sinking, you should use external or Straumann tissue level implant. Thank you. I think OSSTEM has SS type, which is a tissue level implant. That's true. US type was used in the previous case. US type is good. Not a lot of people use it, but those who use it really enjoy it. Chichichi, thank you for the wonderful lecture. In a full mouth case, how is food impaction like compared to fixed prosthesis?
저류라고 말씀하시는 건 이제 그 뭐죠?
I think it has to do with emergence profile.
그거는 뭐 솔직히 저희 그 보철로
In a lot of cases, this cannot be solved prosthodontically. If the patient has thin ridge and high VD, the food impaction is bound to occur. You need to tell the patient this is not about health issue, it's just uncomfortable. Uncomfortable and pain, they're two different things. Using denture may be more easier, but that's not likely. There's a question via YouTube. The cough looks short compared to emergence taper of existing stock abutment or healing abutment. It looks a little bit thick and fat. Does it cause gingival issues?
그러니까 이
Emergence of healing.
힐링의 이머전스. 여기도 힐링 어바트먼트.
Is there a healing abutment? No.
예.
근데 커프가
Cuff is short, but it's not thick at all.
이제 특히 그 오스템 TS
Especially the one for OSSTEM TS.
예.
그 낮은
There is not just a short cuff, but also a cuff up to 2.5 millimeter is available. When you place immediate implant too deep,
아예 이제 세팅
then there can be issues with setting, so there's longer cuffs.
아 예. 우리가 질문이 좀 너무 많은데요. 이 질문을 다 드리기가 시간이
There are so many questions.
관계상 한
Because of time constraint, we'll entertain one more question,
나머지는 개별적으로
and the rest will be addressed individually.
그러니까 쿠
ID Kual.
이란 분이
Harry system seems to have external prosthodontic concept welded into it. In internal multiple case, if the angle is not favorable, the sink down occurs differently for different abutments, and the skirt tightening on the model and in the oral cavity is different. In the case of internal multiple case, it is difficult to get passive fit in screw type. What do you think on that?
이렇게 돼 있습니다.
I think this is a very difficult question.
그렇습니까? 예. 예.
This issue is not just limited to Harry system. I think this is a disadvantage of internal TS type implant.
TS 타입 임플란트가 갖고 있는 약간 단점 같은 거라고 이제 생각하고 있고요.
And therefore,
그렇기 때문에 조금이라도
precise scanning is necessary.
스캔과
And model to connect the scan abutment is necessary.
모델이 좀 필요할 것 같고요.
A lot of dental clinics use internal OSSTEM TS type Harry system.
하고 있는데
If you look at reviews,
그 최근 논문
if you use cheaper knockoff abutments, the issue of sinking down can occur more frequently.
쓰게 되면은 싱킹 양이 많다는 논문이 있습니다. 그러니까
You should use authentic OSSTEM abutments or abutments available from renowned companies.
그런 그좀 많이
Because your lecture is so good, there are so many questions that we apologize for not being able to answer them all. The rest of the questions will be addressed separately.
드리지 못해서 대단히 죄송합니다.
I hope you understand.
나머지 질문들은 개별적으로 이렇게 답을 해 드리는 것으로 이렇게 양해해 주시면 대단히 감사하겠습니다. 그리고 지금까지
Thank you, Dr. for providing wonderful answers. I would like to extend my gratitude to all of you who have raised your questions. Now we'll choose the best question of the day.
베스트 질문을 이제 선정해 볼 텐데요.
Dr. can you choose one question?
선택해 주시면 어떻게?
질문
Among the different questions, I thought the best question was raised by Kual. Kual raised a question in the latter part of the lecture. I would like to congratulate you for being picked.
마케팅 수신에 동의.
Unless you agree to marketing, we will not be able to send you the coupons.
드리는데요.
Kual, please agree to marketing and get your coupons.
대단히 감사하겠습니다. 그리고 선물 꼭 받아가시기를 바라고요.
The real-time chat event continues on in the next lecture as well. I look forward to your keen participation. Dr. Thank you for the wonderful lecture. I'm grateful for getting insight on ZSRP. Last but not least, could you provide a word of advice to your peers who are studying up until late to studying implant prosthodontics?
예. 특히 스캐너를
If you have oral scanners, do top-down approach and place implant appropriately.
제 위치에 잘
You scan using scan body.
그다음에 이제 그거를 스캔 바디를 꽂고 스캔하지 않습니까? 그러면 스크루 타입과 그 세멘 타입
The impression taking method is the same for cement type and screw type.
너무 관성적으로 세멘 타입
Just because you're used to cement type, don't go ahead and use cement type. Why not try screw type after having listened to my lecture? You'll be able to leave better impression to your patients and reduce chair time as well.
체어 타임을 줄일 수 있는 그런 계기가 될 수 있다고 생각합니다.
Thank you for listening. Thank you for coming to Prosthodontics on Friday despite your busy schedule. Dear viewers of Prosthodontics on Friday, did you enjoy the lecture with Professor Sang-ho? I hope you were able to get a lot of tips on ZSRP. I hope you'll be able to utilize it in your clinical practice. As for the questions that were not addressed today, these will be addressed via replies. In the next lecture, Professor Seo Jae-min of Jeonbuk University is going to talk about the biological failures related to implant abutment and prosthesis design. Thank you for staying up with us until late. Thank you.
자, 어머님 수고 많으셨습니다.